this is Kaustubh Kakade and I am discussing surgery with you all. In the last video, we started the thyroid surgery, and under that, we started with a very important topic of a thyroid nodule. We discussed the causes of thyroid nodule, how will they present, and how investigation wise you're going to manage a case of thyroid nodule. Continuing with that, now we are going to study how do you approach FNAC. Yes, what is FNAC, and as a surgeon, what is your role in FNAC, right? So what is FNAC? FNAC is nothing but fine needle aspiration cytology, where a very fine needle. What do you mean by fine needle? So what size of needle are you using? Generally, it is recommended to use 25 to 27 gauge of needle. 25 to 27 gauge of needle. This is a very important question. So this is the needle size. Okay, 25 to 27 gauge needle is to be used, and this procedure preferably is done ultrasound guided. So USG ultrasonography, USG guided, right? This is going to be a USG guided procedure. Now, what are the indications of doing an FNAC? In which conditions are you going to do an FNAC? Yes. So the first indication of doing an FNAC, something that we have already seen in the last video. The first indication of doing an FNAC is a cold nodule in hyperthyroidic patient. In hyperthyroid patient. Yes, why? Because the clinical suspicion of malignancy is going to be high if there is a cold nodule, but the patient is presenting with hyperthyroidism. Secondly, if the patient is hypothyroid and he has a nodule, he is hypothyroid and he has a nodule. Third, if a patient has euthyroid, okay, if a patient is euthyroid and he also has a nodule. But it's very, very important to understand that these two indications are only if they are suspicious. Only if they are suspicious, right? Now, the fourth indication that we want is something new that we have not studied earlier. That was radiation exposure. Why radiation exposure? Because one of the most common malignancies that we are going to see, those are mainly seen in cases of radiation exposure, that is papillary cancer, right? So under radiation exposure, I want you to understand the concept of radiation exposure over here. Okay. Now see, radiation exposure can be divided into two types. Okay. One is a low dose radiation and a high dose radiation. What do you think? What form of radiation, what dose of radiation is going to increase the suspicion of malignancy? Definitely, this is going to be taken based on history. But understand that low dose radiation cause mutagenesis, cause mutation, and this mutation will in turn lead to cancer, right? So this is highly suspicious of malignancy, right? And hence we are going for an FNAC. Whereas a high dose will cause ablation. That means it will destroy the cells, right? So the chance of suspicion is low. So in which case you go for FNAC? In which case you go for FNAC? In low dose radiation exposure, we go for FNAC. In high dose radiation exposure, you are simply going to monitor with ultrasound. Okay, and the fifth indication that you need to understand is family history. The simple reason why family history is because it is associated with familial head and neck malignancies, right? Because it is associated with head and neck malignancies, which are generally familial. Now, let's see what would be done when you get a report of FNAC, right? Now, suppose you have done an FNAC. Firstly, what do you mean by an adequate sample? Adequate sample. Adequate sample is nothing but at least 6 clusters of minimum 10 follicular cells each, right? So suppose this is a slide you are studying. Okay, under this slide, there should be at least 6 such clusters, and each cluster should at least have 10 follicular cells, right? Only then you will call this as adequate. Only then you will call it as adequate. So now suppose you have done an FNAC. Okay. The first possibility that you have is after doing an FNAC, it comes to be inadequate. Okay. It comes to be inadequate. That means this criteria of at least 6 clusters of a minimum 10 follicular cells has not been fulfilled. What you will do next? What should be done next? Do you wait? No. You are already in a suspicion, so you repeat. You repeat, right? Immediately, yes, you are going to repeat. The second possibility that you get after doing an FNAC is it comes out to be benign. Okay, but if it's benign, do you remove the thyroid? No, you will not remove the thyroid because you want to preserve the function of thyroid. It is a very important hormone in many senses, right? So thyroid functions have to be maintained in benign conditions, right? So to maintain those, what you are going to do, you leave the patient as it is? No, you're not going to leave the patient as it is. You're going to monitor with ultrasound. You're going to monitor this patient with an ultrasound. Okay. Now, suppose the third situation that you are getting is you got a sample which states it to be inflammatory. You are seeing inflammatory cells. What this could be? A diagnosis of thyroiditis. A diagnosis of thyroiditis. We'll discuss thyroiditis in the next video itself. But just to remember, thyroiditis generally is to be managed medically. Okay, then the fourth thing that you could get is malignancy. But remember, this malignancy should be a non-follicular cell. Okay, non-follicular one. That means no follicles are formed in this. Okay, it should be non-follicular. Okay, then in such situation that it is a non-follicular one and is malignant, what you will do you wait? No, there are many chances that this may metastasize, because under malignancy, what types you are going to have, right? What types you are going to have under malignancy? You are going to have three types, right? You are going to have three types. One is the most common one, papillary carcinoma of thyroid, and the second is anaplastic carcinoma, and the third is medullary carcinoma. In such situation, what you are going to do is you are going to do depending upon how much of the gland is involved. If it is more than that of a half of the isthmus is involved, then you will go for a total thyroidectomy. Then you will go for a total thyroidectomy. And if it is less than half of it is involved, then you are going to go for a hemithyroidectomy. That is half. Hemi means half. So hemithyroidectomy. So this is the option that you have over here, right? If it comes to be a non-follicular component, right? Now, if you have a fifth property, yes, there is possibility of a fifth variation over here, right? Okay, the fifth variation that is possible is going to be a follicular one, right? You are having a follicular pattern. That is, the cells are arranged like in a follicle. They are arranged like in a follicle in an FNAC as well. Can you diagnose it directly to be a follicular carcinoma? No. The reason behind this is a follicular component can be of two types. It can be follicular adenoma, and adenoma means already you know in pathology, adenoma means it is benign, right? Whereas it could be a follicular carcinoma. So it is malignant, right? It is malignant. So what to do in this situation? How do you identify? How do you identify that it is a adenoma or it is a carcinoma? So the verses between these two are two important points. First important point is capsular invasion, and the second important point is vascular invasion, right? So, how can you get these two? You cannot get these two on a simple FNAC, because in FNAC you are drawing out just the cells using a needle. You're not removing the capsule, you are not removing the blood vessels. So, definitely FNAC fails when it comes to follicular pathologies. So, the diagnosis has to be done with the help of a biopsy, right? How will you get that biopsy? That is your next step. So if it comes out to be follicular, what to do? You are going to do a hemithyroidectomy. Okay, you are going to do a hemithyroidectomy. Half of the thyroid is removed. Now, suppose suppose you are getting, after hemithyroidectomy, what you are going to do? After hemithyroidectomy, you are going to send the biopsy sample, right? You are going to send the biopsy sample. After doing a hemithyroidectomy, you are going to send a biopsy sample. Now, after getting a biopsy sample, the pathologist will report to you. The pathologist will report to you either being benign or being malignant, right? So it will come out to be a follicular adenoma based on this biopsy, or it will come out to be follicular carcinoma, right? So what you will do, if it's a follicular adenoma, definitely you know half of the involved thyroid you have already removed. So what you should do you need to remove the remaining thyroid? No, it's a benign condition. Half of the involved thyroid you have already removed. So what you will do, just monitor with ultrasound for what? Remaining gland, for remaining gland, right? Whereas if it comes out to be a follicular carcinoma, it is malignant. So you will do completion you are going to do completion thyroidectomy. That means you will go back, open the patient again, and remove the remaining part of the thyroid as well. So in toto, in an FNAC, what you are doing, if it comes out to be a inadequate one, repeat it. If it comes out to be benign, you are going to follow up with ultrasound monthly for about 6 months. If it comes out to be an inflammatory, it will be a thyroiditis to be treated in majority of the conditions medically. If it comes out to be a malignancy with non-follicular components, that is either papillary, anaplastic, or medullary, then you are going to simply do a total or hemithyroidectomy depending upon how much of the gland is involved. And if it comes out to be follicular, you cannot differentiate between follicular adenoma and follicular carcinoma. So you will do a hemithyroidectomy, remove the half part which is involved with that nodule, send it to the biopsy for pathology. Pathologist will report it to be a adenoma or follicular carcinoma. If it comes out to be follicular adenoma, that is benign, monitor it with ultrasound for 6 months. For what? The remaining gland. And if it comes out to be follicular carcinoma, which is malignant, you will do a completion thyroidectomy, which is you will go back, open the patient again, and you are going to remove the remaining gland as well. This is how you are going to manage a case of aden- uh, uh, adenoma, a carcinoma, or follicular. And overall toto, this is how you are going to manage a case of thyroid nodule. Thank you for watching this video. Hope you have got the major component of the follicular nodules, toxic nodules, and many things under this section. If you like the video, definitely do subscribe our channel, and comment what you want me to do next, and also follow us on Instagram, Inspiring Minds. Thank you so much.